Good evening and welcome, and thank you for taking time out to listen to me talk to you this evening. So just a little bit about myself. I've worked in IVF now for 38 and a half years. I started back in 1985 working with Robert Winston at the Hammersmith before setting up the IVF service in Leeds, and I've been in Leeds since about 1990, so for the last 34 years. So what we're hoping to do today is take you through the IVF journey and try and explain why we do things and at what point we do things. So a little word about Care. Care have got a number of clinics all over the UK, and we've now got clinics in the US and in Spain. In Spain, they do specialise in egg donation, and branching out in the United States, they too have the benefit of a very good egg donation programme. So the first thing we have to do is we have to establish the right diagnosis and whether IVF is right for you. And to do that, and to make sure that your consultation is worthwhile and the doctor has got something on which he can base his diagnosis, we like you to have some pre-treatment tests. Now, we can accept tests that have been performed either on the NHS or other fertility organisations as long as they've been done to a fertility standard. So the tests that we would look at involve women looking at their ovarian reserve. What does that mean? How active their ovaries are, how many eggs we might retrieve if we were to do IVF treatment. And to measure that, we look at AMH. What's AMH stand for? AMH stands for anti-Müllerian hormone. It's a hormone made by the hormone-producing cells that surround the egg as the egg grows. It's only made by follicles which are actively growing. And it stops being made when a follicle is selected to be released that month. So it's a good guide to how many follicles you have in your batch that are actively growing. The pelvic ultrasound scan looks at an antral follicle count. These are the structures containing eggs that have taken 9 months to go from their resting stage to the antral follicle. And at the beginning of your menstrual cycle, one of these small structures between 2 to 8 millimeters across will be chosen to grow, and the egg will be released from this follicle. You only release one egg per menstrual cycle, and it comes from this batch of antral follicles that is present at the beginning of your cycle. You may have 2 or 3 waves of antral follicles during the course of your menstrual cycle. But this gives us a good guide, again, to how many eggs we're going to retrieve at the IVF process. If you have an antral follicle count of 15, we might expect to retrieve around about 15 eggs. If your antral follicle count is low, at 4 or 5, we may only get 5 or 6 eggs at maximum. We can't manufacture eggs from nowhere. These follicles have taken 9 months to get to the point where we can stimulate them. So they have to be at the right stage of development. So the antral follicle count and the AMH give an idea of how many follicles you have and how many of those are actively growing and therefore available to us for selection. We also need to know that there's going to be some sperm. So we want to look at the sperm sample. We need to know how much the volume of the ejaculate is, how many sperm you have, how many of them are moving in the right direction. And we also need to know about whether they look normal or not. So those are the three basic tests that we need. There are some other tests that we do need. For example, when you're about to start the treatment, we need to know that your thyroid gland is working well. It's really important in early pregnancy. We need to know you're not anemic and you've got a normal full blood count and your platelet count is normal, just like you would before any surgery. We also want to know in certain patients, particularly those with polycystic ovaries, whether there's any evidence of diabetes. We also want to do an infection screen by putting a small catheter. We're putting a small catheter through the neck of the womb with the embryo. We want to make sure we're not going to transmit an infection from the cervix into your womb cavity. And we also want to check your vitamin D levels, because vitamin D, a large portion of our population has been shown to be deficient in vitamin D, and it makes a big difference if you've got the right amount of vitamin D in your circulation on the chance of a successful outcome. These tests will all be discussed at your consultation. At Care, the consultations last for about an hour. 45 minutes in front of the doctor, and then 15 minutes for the doctor to do all the forms that you need and make sure that your treatment plan is put on your electronic record and that all requests for any additional tests are organized, and a plan is put together for your treatment. So this overall, you get an hour of time for that first initial appointment. And we'll take a history, both from the man and the woman, to see if there are pointers in the history which may help to demonstrate the type of infertility you have and help to judge how successful you might be with the treatment process. So let's now talk about the IVF process. The first thing I want to say is that this is not a frightening process. This is a process which does involve things which you may not have experienced before. It involves stimulation of your ovaries. It involves having ultrasound scans, and it involves having eggs collected, sperm collected, and then mixed together to form embryos. So how do we do that, and why do we do it? Going back to the ovarian stimulation, women are born with all the eggs they will ever have. They're like an egg warehouse. As soon as you're born, the doors to that warehouse are open and the eggs start being selected. We don't know what controls that. We've got no control ourselves. You haven't got any control over it. But as I said earlier, it takes 9 months for the follicles containing the eggs to grow to the antral follicle stage, at which point they can react to the hormone, follicle stimulating hormone, which is a hormone released by your pituitary gland, which is sited at the base of your brain. All the follicles that start to grow before puberty don't get very far in the development process. But normally a woman would lose about half her follicles before she reaches puberty. From puberty to the time of the natural menopause, which on average in the UK is 51, a woman will ovulate potentially 450 mature eggs in her whole lifetime. So how does the body choose which follicle to release? So when your hormones are at the low ebb, when you're on your period, the group of follicles that are there at that time, imagine that you've got 15 glasses of water in front of you. And they're all at different levels of fullness. Some are nearly empty, some are half full, some are nearly full. In your hand, you've got a jug of FSH, follicle stimulating hormone, and you share it evenly between the 15 glasses, the one that's closest to being full will overflow first. As soon as it overflows, you stop pouring the FSH. That's how your body selects a follicle to be released. It's the most sensitive follicle to the hormone FSH. What we do in IVF is, instead of giving you 2 pints of FSH, we give you 10 pints of FSH. So we can fill more of those glasses. So more follicles will grow. Furthermore, we don't just stop when the first one overflows. We want to keep it going, and most women will need 10 to 12 days of FSH injections before they're ready for their egg collection. So we might get some follicles from the first cohort, we might get some follicles growing from the second cohort. So by the time you come round to day 10 or day 11 of your cycle, you may have some follicles that have reached 11 to 12 millimeters in diameter, but you may have some at 13, 14, some at 17, 18. And normally we would want at least 3 above 17 when we give you the trigger injection to time your egg collection. You might ask, why do I have to have injections? Can't I have a tablet? And the answer to that question is no, because FSH is a natural human hormone. And it's a protein, and if you were to take it by mouth, you would just digest it like a piece of meat. So it has to be given by injection. But don't worry, the illustration on this slide shows it's a big, long needle. It's not. It's a tiny needle. It's a very, very small needle. And it goes just underneath the skin. When we judge that the follicles have reached the right size, and we don't worry, there's a picture of the needle just going in, then you can see it, and the nurses will practice with you to demonstrate exactly how easy it is to give. And we monitor you with ultrasound scans, and most going through the infertility process will have already had a pelvic ultrasound scan, and this is one of our consultants here who's just setting up the ultrasound machine. And normally that scan is done around day 9 to 10 of your treatment. Now, occasionally we might do a scan a little bit earlier if we think you might be at risk of producing too many small follicles, and we might want to reduce the dose. And so we might scan you earlier to day 7. When we judge the time is right, we give you a trigger injection, and this has to be done at a very precise time. It needs to be done 36 hours before your egg collection. So if we're timing your egg collection for 8:30 in the morning, we give you the trigger injection at 8:30 in the evening, 36 hours beforehand. What's so important about the trigger injection? The trigger injection does 2 things. It will initiate the process that would lead to ovulation at around about 40 hours. In that process, the egg is freed from the wall of the follicle and it floats in the fluid. So when we stick a needle into the follicle to drain it, the egg's just in the middle of the fluid and it comes out easily. And we get eggs back in around about 8 out of 10 follicles that we stick a needle into. The second thing that happens with that trigger injection is it reinitiates the process of getting rid of half the female chromosomes, so that when it meets a sperm with half the set of chromosomes, it can form a new whole. And that process is initiated with the ovulation trigger. The egg collection, again, please don't worry about the egg collection. It's really, really straightforward. It's generally performed under a sedation anesthetic. What that means, it's conscious sedation. You're not asleep, but you're not awake. You won't remember anything about it. We often use some local anesthetic in the vagina as well, which hopefully will numb the top of the vagina and mean you need less sedation. Some women talk their way all the way through the egg collection, but they can't remember what they said at the end of the procedure. And what we do is we put a needle through the top of the vagina into the ovary, and you can just see a picture of the ovary with the needle in a follicle here in the second image. And we suck the pressure out under a low suction pressure, and it goes into a tube, and that tube is then examined by the embryologist. Each egg collection is done as a day case procedure, and it takes around about half an hour to do. The sedation we give you is midazolam. Its other trade name is Hypnoval, so it does what it says on the tin, it hypnotizes you. And the other drug is fentanyl, which is a narcotic, water-soluble painkiller, which is really, really effective. Once the eggs are collected, we then need the man to produce his sperm. And can we show the first sperm video, please, Sam? So here you can see slides of little sperm, and this is what sperm look like, and this is how they travel. And you can see some of them move quite quickly. And what we're interested in is how many of them are moving in that forward progressive manner rather than just standing on the spot and shaking. And what we're looking for when we're going to inseminate the eggs, if you've got a really normal sperm count, greater than 15 million per mil, a volume in the ejaculate of greater than 1.5 mils, progressive motility of more than 30%, and normal sperm greater than 4%, we will use standard insemination, where we prepare the sperm and then we inseminate the eggs by placing the sperm in the petri dish in eggs together. If you don't have a good sperm count, we can use ICSI. ICSI is a process where we inject the sperm into the egg cell. This was developed by accident. They were trying to put a sperm inside the eggshell, the zona pellucida, but outside the egg, but they slipped and the sperm went in and it fertilized. So they thought this was a good idea, so they did it again and it worked again. So this is how ICSI was born, developed, and it was developed in 1992 in Brussels. And since then, it has revolutionized the treatment of male infertility. Sam, would you like to show the ICSI video? This fascinates me. So here you can see the egg, which is held in the position. You see the sperm just at the edge there of the glass pipette. You suck up to break the egg sperm membrane, and then you inject the sperm. Here it goes, and there it is. The sperm is coming down. You can just see it there in the egg cell. It is amazing technique. You'd think it would do lots of damage, but it doesn't. The fertilization rate with ICSI is just the same as we would expect with normal fertilization, between 65 to 70% of eggs. We then check about 16 hours later to find out whether the eggs have fertilized. And we put them, when they are fertilized, in an incubator. And we leave the fertilized eggs for 5 days in undisturbed culture. Because we know if we don't disturb them, they've got a better chance of getting on and developing unhindered. Opening the incubator doors and checking them too often doesn't help, because it changes the temperature, changes the gas environment, and embryos don't like that. At Care, we like to use Care maps. an artificial intelligence program which monitors the embryos very closely. We take a picture of the embryo every 10 minutes, and then at the end, we come up with a score. It's a computer program generated from over 6,000 healthy babies. And what it does is it tells us a score out of 10, which gives you the chance to know how good an embryo that is, what chance it will give of giving you a pregnancy. And it's won a number of national industry awards at the Royal College of Pathologists in the last year. Would you like to show us the embryo development incubator? So here you can see a small embryo. It multiplies all the time. From the time it fertilizes to the time we look at it and put it back, it's developed into a blastocyst embryo, which contains between 120 and 160 cells. It develops into an inner bit that's going to form the baby and an outer bit that's going to form the inner cell mass. And on this embryo on the screen now, you can see it's beginning to hatch out of its eggshell, the zona pellucida. So that's the time-lapse imaging. Now, as you get older, one of the main reasons why you become less fertile is that the process of getting rid of half the female chromosomes from the egg starts to go wrong, which means that there is a higher chance that the embryo is abnormal. For example, at the age of 38, approximately half of the embryos that look good may be chromosomally abnormal. If we select out the embryos that are abnormal and only put back embryos that we know have got a normal chromosome complement, just the same as you and I, then that's going to improve the chance of that embryo forming a baby. And it would change from maybe at the age of 38, a 30% chance of implantation to a 60, 70% chance of implantation. So it makes a big difference. And that's called PGTA, where we take a biopsy of the embryo. Sam, would you like to play the video? And we wait for the embryo to begin to hatch. And then we take a small section of cells from the embryo. And those cells, it's from the afterbirth part. It's not affecting the inner cell mass that's going to form the baby. And those cells are then taken off. The embryo is then frozen. And those cells are then analyzed genetically. And we find out whether they're normal or not. And the abnormal embryos are not kept and the normal embryos are kept. It does mean that you will need to defer the transfer for about 6 weeks in a frozen hormone replacement cycle. But I think that certainly if the opportunity is that you'll produce a lot of embryos, it's good to know that the embryos you have in the freezer are normal and give you a good chance of a successful outcome. And we do freeze any spare embryos. IVF, we like to put one embryo back at a time. And the reason for that is we don't want you to develop twins. Why are twins bad? 1 in 12 couples that will have a twin pregnancy will develop either a dead or handicapped baby. We want you to have a healthy baby. And therefore, one embryo at a time gives you the best opportunity to do that. Back in the early 2000s, there was no real regulation. And up to 25% of all IVF treatments would result in a twin pregnancy. And all the neonatal cots in the country were full of IVF babies. Now, the IVF process, because we grow the embryos to the blastocysts, we only put a single one back. The chance of success is better now than it was then, and it's safer, and you're more likely to have a single embryo. There is a small chance of twins if the embryo divides into two, and there's not a lot we can do about it, and then we have to manage it the best we can to give you a healthy pregnancy. Any spare embryos that are suitable will be cryopreserved. We use a process known as vitrification. It's rapid freezing. And about 98.5% of embryos survive the freeze-thaw process when it comes around to putting them back. And the success rate with the frozen embryos is just as good, if not slightly better, than the fresh embryos that are transferred. The embryo transfer itself is fairly straightforward. You do need a full bladder. You don't need any anesthetics. It's performed usually under ultrasound control, so we can see precisely where we put the embryo back. We use a very fine catheter that goes through the neck of the womb, and then put the embryo in with a tiny, tiny little droplet of fluid. So it's a really small droplet of fluid. And then we check a pregnancy test around 13 days later to find out whether it's worked or not. Of course, there are other treatments, and some patients won't need IVF. You can have IUI. And for example, IUI is a great treatment if you're unable to have sex for any reason, and we can prepare your partner's sperm and put it through the neck of your womb. If you're having donor sperm treatment, then IUI is the way to go. We prepare a sample of sperm, and when you're about to ovulate, we put the sperm through, freshly prepared sample through the neck of the womb. And that's used, if you use in a same-sex couple, we can use IUI treatment. The choice of whether you have IUI or IVF, there's lots of factors that we need to take into account. For example, your age. If you are getting into your late 30s, early 40s, it might be wiser to think about IVF rather than IUI. But if you're in your early 30s, then IUI might be a better option. IUI is not recommended in the NICE guidelines if you have got a normal sperm count and you are just ovulating naturally. Randomized trials have not shown that that improves the outcome compared to just having sex. Shared motherhood. Some same-sex couples would like both partners to be involved. It's sometimes known as reciprocal IVF. And basically, one of the partners donates the eggs to use in the IVF treatment, and then the partner carries the baby and becomes the gestational birth mother. So you've got a biological mother and birth mother. So you're both sharing in the process. What about donation with care? Now we can have either sperm or egg donation. We have our own sperm banks and we have our own egg banks, but we also work with a lot of partners overseas, in particular the California Cryobank, Cryos International, European Sperm Bank, the London Sperm Bank, and also with Brighton Fertility Associates. You may have another clinic that you've got some knowledge of and you want to use their sperm, but you have to bear in mind that if we are importing sperm from overseas, that it has to be compliant with UK law. And so those clinics need to prepare and provide the samples in the UK compliant with our law. Otherwise, it can't be used. Likewise, you can't import eggs from clinics that pay the donors or the donors are anonymous. Care Fertility has its own egg bank. It's one of the leading providers of egg donation in the UK. And what we do is we have altruistic donors that come forward wishing to help infertile couples, and they go through a cycle of IVF, just like I've explained, and we freeze their eggs. This means that you then can register to get onto the egg bank. You can choose a set of eggs, a standard set or a large set, and then they're allocated to you. You then are prepared. Your lining of the womb is prepared, just like we might do if we're doing a frozen embryo replacement cycle. And when we know that your endometrium is appropriately developed, we'll then thaw the eggs, fertilize them with your partner's sperm, grow the embryos through to the blastocyst stage, and then put an embryo back through the cervix into the uterus, just as we would do with a fresh transfer. The difference is that you would need to take hormone replacement therapy up to 12 weeks to support the early pregnancy. We can also provide surrogacy. We work with a number of the surrogacy organisations in the UK, and you can provide your own surrogate. That might be needed, for example, with if you don't have a uterus. It's called host or gestational surrogacy. And some women are born without a uterus. Some have to have their uterus removed because they've got cancer, but they keep their ovaries, they can produce their eggs, and then we can use your husband's sperm, your eggs, to form embryos that can go back into a host surrogate. Sometimes you might do direct surrogacy, where the surrogate herself provides the egg. You may do this in a same-sex male couple, for example. Some same-sex male couples will decide to go down the host surrogacy route, using an egg donor and their own sperm to create embryos. So there's no direct relationship between the surrogate and the pregnancy. There is a choice, and this, it's important to have that choice. So what I hope I've shown is that there are a number of ways that we can help all types of couple have a family together. We believe strongly at Care that fertility is for everyone. We have lots of support at Care Fertility too. We have an app which you get when you register, so that we can help provide you with loads of information, easy to chat to our team of advisors. It helps when you have got invoices to pay, to securely pay your invoices. And there's also lots of information there about the medications and the procedures. And if we need to give you an urgent message, it's far easier to give you a text and than try and necessarily phone you at busy times of the day. We have a number of payment plans. We work with Access Fertility, who provide the payment plans for our IVF patients. You've got refund programs, multi-cycle programs, IVF donor egg refund programs, and there's a number of these programs that you can choose. And some of these include free credit options, interest-free credit options as well, which is particularly important nowadays in today's difficult economic times. Care have just put together a fertility check, which I believe is available till the 30th of June, where you can have a full fertility check, an MOT, for £449, which includes a scan, a sperm test, the AMH test, and then an initial consultation with one of our Care Fertility experts closer to you. And anybody can take up this offer. Other ways of support, we have a number of events, fertility events. We have a fertility forum We've got egg share and egg donation information on the website. So have a look at the website and explore it to see what support we can provide. We have a new patient inquiry team. If you're a new patient, when you first come onto the team, and they'll help you choose the right clinic for you. We have care pals in each clinic. In Leeds, we have 12 dedicated care pals who see you through the fertility journey, that after you've seen the consultant, they'll be in touch generally within 48 hours with a host of documents to help you on your journey and guide you through this process. We've got a care resource hub, lots of really useful information. We can provide support counselling, where counselling is mandatory as part of the treatment process, such as in donation cycles. We can provide that too. There are a whole host of different social media platforms that we can help with as well. So I hope that's been helpful. We've come to the end, and there are, I think, quite a few questions on the chat already. And so if you've got any other questions, please add them now, and then we'll try and go through them in turn. Thank you. So I'm going to start right at the beginning, okay, of the questions. And the first question I've got on here, is there any specific protocol, dose of FSH for women who have polycystic ovaries because they have a high risk of OHSS? Yes, ladies who have polycystic ovaries, they've got lots of little follicles. They've generally got a high AMH level, and they are more likely to develop ovarian hyperstimulation syndrome. Therefore, we tend to use what we call a short antagonist cycle. And the advantage of this means that we can give you a different type of ovulation trigger, a GnRH agonist trigger, which stimulates your body to produce its own LH surge, rather than use the normal trigger we use in IVF, the pregnancy hormone HCG. The advantage of this approach is that the LH surge lasts a shorter period of time, less stimulation to your ovaries than using the HCG, which lasts in your circulation 5 times longer. So we use a short antagonist approach, and we'll use a lower dose of FSH. It doesn't really matter which FSH preparation you use, but we will use a lower dose of FSH. It's sometimes very difficult to get the dose right, because you have to take into account your weight, and until you've actually been through the treatment itself, we don't know how you might respond, because all the tests we do, the AMH, the scan, they're just surrogate markers, and it's really the stimulation process itself which will give us a true guide. What's the tendency of having ectopic pregnancy with IVF? Now, that's a really good question. There is a risk, because we're putting the embryo back into the womb. The embryo is not implanted, it's transferred. And it's transferred in a small droplet of fluid. And it may move around inside your womb. The little hairs on the endometrial cells might shift it into a place, and it might go up into your fallopian tube. If the tube is damaged, it might stay there and form an ectopic. Thankfully, the rate of ectopic pregnancy after IVF is about 3%. So 97% of IVF pregnancies in the right place. What anesthetic or sedative drugs are used in the egg collection? I think I mentioned that earlier. The only other drug that we might use as a bit of a top-up to help you if you're finding it a little uncomfortable is some propofol, which is an anesthetic agent. But that is only provided in those clinics where there is a consultant anaesthetist available. Please can I ask what the success rate for IVF with someone having endometriosis? So the chance of success, if you look at the HFEA website, they used to, many years ago, keep a list of all the different causes of infertility. And there was no difference between the rates of infertility associated with endometriosis compared to those having tubal pathology. Now, there are some women with endometriosis where the condition is so bad that it starts to affect your ovarian function. And when that happens, you may not produce as many eggs, and therefore it will have an impact on your chance of success. Does ICSI have better success rates? Now, that's a very good question. And I think the very early studies seem to demonstrate that ICSI would give better success rates. But actually, if you look at the data, we did a randomized controlled trial in the mid-90s with 4 other IVF units in the country. And we demonstrated quite clearly that if you've got tubal disease, you've got endometriosis, then ICSI does not give you a better chance of success compared to just standard insemination. But what ICSI does is if you have got a very low sperm count, that the egg itself, generally, the low sperm count is the cause of the infertility. And the egg is going to be from a healthy woman. And therefore, that gives a very good chance of success. I've factor 5 Leiden and had a previous DVT and P and wish to potentially look at shared motherhood with my partner with the possibility of using my egg to carry our child with a sperm. Is there a possible son with factor 5 Leiden? It is possible. I think we do need to make sure that the dose of stimulation that we use is proportionate. We don't want you to overstimulate. We can give you some blood thinners to help. And from your history, it would suggest that we would routinely use blood thinners. We stop them for a short period of time while you have your egg collection and then start them again afterwards until the ovaries have settled down. So yes, Emma, it should be possible. Is there gender selection for family balancing? This is illegal in the UK. You can't do that in the UK. There are clinics abroad where it is legal, but it's not legal in the UK. Now, our success rates, I think that one's been answered. Okay, so Stephanie's asked whether we do ICSI if somebody had already had IVF that resulted in no embryos. Now, if you have a failed fertilization, we would generally use ICSI the next time, even if the sperm looked normal. However, ICSI will not correct a problem in the egg cell itself. But if there was something that hadn't really been noted between the egg and the sperm, ICSI would certainly allow a good chance of fertilization, but it will not correct an egg problem. Now, next question. Okay, so IUI against IVF, it depends on the reason why you're doing IUI and your age. So we don't just do 1 cycle of IUI in Leeds, we will do up to 3 cycles, but it depends on your age. And sometimes in some couples we'll do up to 6 cycles of treatment. But age is important. And the reason for that is that as you get older, your eggs have a higher chance of being abnormal, naturally, as well as they would be in the IVF process. For example, at the age of 38, your best embryos, 50% of them are going to be abnormal. At 40, 66% of your best embryo is going to be abnormal. That same process happens naturally. So you could go through more IUI cycles and still only get abnormal eggs forming abnormal embryos. So as you get older, IVF, because you're producing more eggs, there's a better chance of finding an egg that is normal. And that's why IVF. So that 1 amp of sperm that you use goes further with IVF than it would do with IUI. Now then, where is that we've got to? Okay. For same-sex couple, what's the benefit of doing ICSI over IVF? I think this really depends on the sperm quality. In most circumstances, we would do standard IVF, but occasionally the sperm, when it thaws, isn't as good as we'd liked. And therefore, to give you the best chance, we would have recommended ICSI under those circumstances. Shamala's asked a very good question. Does analyzing cause any issues to the embryo? So an embryo biopsy is generally an extremely safe procedure, with around about 95% of embryos surviving the biopsy process. So it's a very safe procedure. Somebody has also, Lara's mentioned, do you recommend any particular type of supplements leading up to the first consultation? That's a really good question, Lauren. I know it's not the feature of tonight's program, but yes, it is. I think vitamin D, really important. 84% of our population is vitamin D deficient, particularly in the winter, less so in the summer months. And we know that if you are deficient in vitamin D, it affects your success rates. A study from Birmingham showed that in average women under 38, if you had low levels of vitamin D, you were deficient, then the chance of a successful pregnancy was 22%. If you had sufficient vitamin D to satisfy your bone health, normal bone health, it was 27%. We like your vitamin D levels to be above 75 nanomoles per litre for fertility. And if they're above 75, it's a 37% chance of success. So here you have a simple vitamin D tablet, which makes a huge difference to your chance of success. There's limited evidence that coenzyme Q10 may also help. The dose is 200 milligrams 3 times a day. And that's given for 60 days before your IVF. And so there is some evidence that too will help. Folic acid is important because we know that it halves the risk of spina bifida in people trying to get pregnant. Okay, now then, now what else is there in here? Right, so Amy's asked, are there any convincing evidence of long-term complications to the female after IVF? And the answer to the question is no, there isn't really. Any hard evidence suggests there's long-term complications following IVF. A common question I get asked is, will it give me an earlier menopause? And no, because as I tried to explain at the beginning, we're only using up eggs that were otherwise destined to die. We're not using up your egg stores. We can only stimulate the eggs that are already developed. And in a natural cycle, those that weren't selected would just go down the conveyor belt into the dusty bin. So what we're trying to do here is rescue eggs destined to die, to make better use of those eggs. And there's no evidence that there are any real significant long-term complications after IVF. Would you recommend PGTA? Chloe's asked, would you recommend PGTA for those women with recurrent miscarriage? Absolutely, Chloe, because we know that those women that have recurrent miscarriage, that's more than 3 miscarriages, have a higher incidence of having abnormal embryos. So it's worth looking at their genetic content of those embryos at an earlier age than we'd normally recommend PGTA. Now, do I need to let my midwife know that I've done IVF? Letting your midwife know that you've had IVF isn't essential. But what is important is that we know exactly when you conceived. So don't let them try and tell you that you've got a different gestation and delivery date based on their scans, because you know exactly when that embryo went back. You know exactly how long that pregnancy is going to be. From the time of the egg collection to the time of the delivery, that's 38 weeks. And we know that exactly. Whereas when people calculate a 40-week gestation from the time of the first period, of course, you don't do that with IVF, because the drugs may not have been started on the first day of your period. So that's not accurate. So you have to go from the timing of the egg collection, not the embryo transfer. If you've had 3 cesareans, can you still have IVF? Yes, you can. Obviously, there are increased risks. The more pregnancies you have, the more cesarean sections you have. And it depends on your age as well. But those are sort of decisions which you should discuss with your clinician. And if your partner's got a low sperm count, and you're worried, if you've got a history of recurrent miscarriage and your husband's got a low sperm count, generally speaking, recurrent miscarriages, the recommendation from the Royal College of Obstetricians is that you no longer check the karyotype, because you only find an abnormal chromosome complement in around about 3% of couples. However, if a man's got a sperm count of less than 5 million, he has about a 5% chance of having a chromosomal abnormality. But if he's got a count of less than 5 million, it's unlikely that you would conceive naturally. But if you're going through the IVF process and having ICSI and your count is less than 5 million, I think it's not unreasonable, and you've had miscarriages, to do a chromosome test. And what else is that is now, Sarah's asked whether or not the NHS and Care can we get the results of tests on the GP. Normally, what we do, Sarah, here is we ask you to get copies of the tests. Sometimes you can get it on your own personal health app, but we get copies of your tests, and then you can upload them onto your Salve app, onto your portal, and therefore we have copies of those results. And we don't need to repeat tests that have already been done by your GP. We just need sight of those blood tests. Occasionally, for example, in Leeds, I've got access. I have an honorary contract with the Leeds Teaching Hospitals Trust, and I can access results that have been ordered through the general hospital computer program. So I can get some tests ordered through GPs. But the easiest thing, if you have tests performed by your local GP, is to get copies of the results. Do you need to inform your GP of having treatment? You don't have to, Hannah, but I always think it's a good idea that you let the GP know, because he is your principal healthcare professional, and if there are complications of treatment, it's better that he knows that there are complications of treatment and the reason why they've developed. So I always think it's best to be open unless you've got a very strong reason why you don't want to do that. How long is the wait to start treatment? So we don't have any waits to start treatment. Generally, the wait depends on your period. There's a 2 to 3 wait to see one of our specialist nurses to get a nurse planning, and then the treatment is, the timing of the start of the treatment is generally discussed at that point in time. So we don't have a long waiting list to start treatment. So I think Chloe again has come back about the best options when suffering with recurrent miscarriages. I think it is to do IVF with PGT, to use progesterone. And there are also some other things that we can look at, and that's to check to make sure that there's no, you haven't got an acquired blood clotting disorder called lupus anticoagulant, and also that the bugs in the vagina, your endometrial microbiome is normal, and there are tests that we can do to look at that, and we can discuss that in the clinic. Can you combine private care and NHS-funded IVF because the waiting lists are long? In Leeds, our policy is that we can see you for private consultation. We can then complete the investigations privately, but if you are eligible to have NHS treatment, you can then have your NHS funded treatment if your GP has already sent a letter through and you're on the waiting list. So we can do it that way. What we can't do is give you initial private consultation and then do NHS tests, because the consultation on the NHS is funded with tests. Okay, so I think actually, I'm afraid we've come to the end of the time. I will attempt, if I can, if Sam sends me the other questions that haven't been answered, I'm more than happy to answer them over the weekend and send you answers back through Ashley and Sam. I hope that's been really helpful.